Then moving on to sickle cell anemia. So sickle cell anemia, again, it is an intracorpuscular defect, but here it is a hemoglobin defect. So we are done with the enzyme defects also. So other enzyme defects like pyruvate kinase deficiency, 5-nucleotidase deficiency. So these enzyme deficiency can also result in hemolytic anemia. Okay. But we are not going to the depth of it. But next we'll see about the various hemoglobinopathies which can result in the hemolysis, intracorpuscular hemoglobinopathies, right? So this is an autosomal recessive condition. HS was autosomal dominant, G6PD was X-linked recessive, while sickle cell anemia, thalassemia are going to be autosomal recessive. So here there is going to be a point mutation. So the point mutation here is going to be a missense mutation. So it is a missense mutation which is going to convert glutamate residue. So the amino acid glutamate is going to be converted into the valine residue at the 6th position of the beta chain of hemoglobin. Okay. So hemoglobin has alpha chain and beta chain. In the beta chain at the 6th position, the glutamate which was present is going to be replaced by valine. So valine wins. Okay. So this missense mutation, this change in amino acid is going to lead to the formation of HBS. So normal hemoglobin is going to be HbA, which is alpha 2 beta 2 chains, while this is HBS, wherein this everything has been changed by changing a single amino acid, right? So now let's see about the various hemoglobins which we know of. So, and in the embryonic age group, that is less than 8 weeks of intrauterine life, we have embryonic hemoglobins, 4 of which is important. So hemoglobin embryonic 1 and 2, then Portland 1 and 2. Then apart from that, we have fetal hemoglobin. So from 8th week of intrauterine life to at least 6 to 7 months post birth, okay, until the maternal antibodies are removed, we are going to have the HbF. Fetal hemoglobin is there up till post 7 months of birth. So HbF is going to be alpha 2 and then gamma 2. Okay, alpha 2 and gamma 2. Then adult hemoglobin, it is going to start forming from 30th week of intrauterine life, and before birth the formation is going to be complete. Okay, but it is the mature adult hemoglobin is going to take up. It is going to become the major hemoglobin only after 7 months of life in postnatally. Okay, so this adult hemoglobins are HbA and HbA2. This adult hemoglobin HbA is going to comprise of alpha 2 and beta 2, and it is up to 96% usually. And then HbA2, it is a minor component, less than 3% only, and this is going to be alpha 2 and delta 2 chains, right? So in sickle cell anemia, what happens is that we are going to have HBS formation. So this HBS can either be HBSS, that is both the alleles can be of HBS, or it could be HBAS, that is a combination of adult hemoglobin with the sickle cell anemia. So when it is a homozygous state like this SS, it is going to result in sickle cell anemia itself, the disease. Then if it is a HBAS, a hybrid of HBA and HBS, that is both the hemoglobins are going to be present, in that case it is going to result in sickle cell trait. Okay, only when hypoxia is there, when you induce it, you can see this defect, sickle cell trait. So what happens in the pathogenesis of sickle cell anemia is that whenever there is hypoxia, there is decreased oxygen, it is going to, these RBCs are going to form sickle cells, because this there is going to be polymerization of this HBS. So whenever HBS is there, it cannot tolerate hypoxia. So it will undergo polymerization, and this polymerization will result in the formation of sickle cells. So once this hypoxia is being relieved, so it is going back to the normal RBC shape. So this cycle is going to come back and forth. Okay, so it is becoming normal, then it is sickling, then it is becoming normal, then it's going for sickling. So this is returning. Repeated cycles are going to be there, and finally it is going to cause irreversible sickling. At some point of time, it is not going to return back to normal, it is going to cause irreversible sickling. So irreversible sickle cells are going to be stiff and sticky. So it is going to make the RBC stiff and sticky. So sickle is like a sickle, right? So sickle is something we use for harvesting crops. It is going to look like this, right? So the cells are going to be like a sickle now. So these cells cannot deform properly. So they are quite stiff and they are sticky as well. So what will happen once they are stiff, they cannot deform properly. So when they pass through the splenic sinusoids, it is going to cause extravascular hemolysis. Apart from that, they are also sticky, right? So sticky in the sense these RBCs tend to get attached to the small vessels. Okay, as and when they pass through the small vessels, they tend to attach to the endothelium. So microvascular occlusion is going to be there. So when they keep on sticking to the small vessels, blood flow is going to be occluded, right? So it is going to cause microvascular occlusion, and it is because of this microvascular occlusion there is going to be lots of complications in the sickle cell anemia. So what are the factors which affect sickling? So as I mentioned, anything which is going to cause hypoxia is going to cause sickling. So hypoxia as such, then acidosis, exercise, decreased pH, all of this is going to cause acidotic state, dehydration again. So all of this is going to cause an acidotic state, which again can induce sickling. Then we have other hemoglobins as well. So the presence of other hemoglobin will also determine the type of manifestations the patient is going to have. So suppose there is a HBSS thing. So there is going to be severe sickle cell anemia. But if you have a HBAS, so there is some kind of normal adult hemoglobin as well. So some part of adult hemoglobin is there, some part of this bad hemoglobin HBAS is going to be there. So some amount of sickling is going to be prevented. So they'll have limited symptoms. And same goes for HBSC. So there is another abnormal hemoglobin called as HBC. So there is going to be combination of HBC and HBS in this condition. So this again is going to be kind of more protective than a HBSS. Not protective as such. It is also going to lead to disease only, but it is not as severe as a HBSS, homozygous state. And then the presence of HBF. So HBF is capable of delivering oxygen, right? So this HBF in that is why these patients, these kids, the patients of sickle cell anemia, they don't manifest even in a homozygous state in less than 6 months of age, because less than 6 months of age you still have HBF levels which are at higher levels. So post that they'll start manifesting. So based on the presence of other hemoglobins like HBA, HBC, HBA, the HBF, the manifestation of this disease is going to vary. So clinical features, again, being an extravascular hemolysis, you are going to have anemia, jaundice, splenomegaly. So one thing important in sickle cell anemia is that there is going to be autosplenectomy after a point of time. So initially it is going to be splenomegaly with extravascular hemolysis, but as the disease progresses, there is going to be this microvascular occlusion I told, right? So when they are going to occlude the splenic vessels, it is going to cause multiple infarcts in the spleen. So with multiple infarcts in the spleen, so occlusion of the vessel, the blood supply is not going to be there, right? So when there is multiple occlusion, it is going to result in infarcts, and because of the infarcts, the spleen will undergo degradation by itself, leading to autosplenectomy. So autosplenectomy, you see it in sickle cell anemia, and that is because of the microvascular occlusion. So coming to the complications of sickle cell anemia. So usually when you get a history of sickle cell anemia, in the exams, the history is usually related to the complications. Okay, so firstly you are going to have acute chest syndrome, then chronic non-healing skin ulcers, priapism, then we are going to have osteomyelitis, especially osteomyelitis with salmonella. So normally salmonella doesn't cause osteomyelitis here, right? But in sickle cell anemia, salmonella is the most common organism causing osteomyelitis. Then you are going to have avascular necrosis of the femur, then hand and foot dactylitis, right? So all of this is going to be actually because of the microvascular occlusion. If you think of it, when the small vessels are being occluded by these RBCs, blood supply is going to be diminished to the end organ, whichever was being supplied. So there is going to be avascular necrosis of the femur. Same thing for hand and foot dactylitis. The patient is going to complain of pain in the hand and foot. So because the small arteries at the peripheries are going to be occluded. Then priapism also is the same thing. So continuously there is going to be priapism. Then acute chest syndrome, they'll have lung complications. Then non-healing ulcers, again without blood supply, the ulcers are not going to heal. The same thing is going to happen there as well. Okay, so these are all the complications of sickle cell anemia. When coming to the crisis, so sometimes the sickle cell anemia can worsen all of a sudden. That means that they had gone into some crisis. Usually they go into aplastic crisis. Aplastic crisis in the sense, not just anemia, they are going to have all kind of pancytopenic kind of picture. That is usually because of parvovirus B19 infection. So parvovirus B19 infection is going to cause aplastic crisis because this virus is going to affect the bone marrow precursor cells. Then sequestration crisis, meaning all the blood is going to be taken up in the liver. They are being sequestered to the spleen. Okay. So when all the blood is sequestered to the spleen, the patient is going to go in for a massive shock. So hypotension and shock is going to be there. So it is quite severe. Then hemolytic crisis, all of a sudden multiple sickling is, lots of sickling is going to happen, and all the RBCs are going to be lice, leading to a hemolytic crisis. Then vaso-occlusive crisis, again all the complications we mentioned, right? So because of the microvascular occlusion, suddenly there is going to be vaso-occlusive crisis as well. So what are the findings in sickle cell anemia? So starting with hemoglobin anemia, so it is going to be decrease. So bilirubin levels being being hemolysis, there is going to be increase in unconjugated bilirubin. So LDH levels will be elevated in both intravascular and extravascular hemolysis, so doesn't matter. Then ESR, so what is going to happen to the ESR? It is going to diminish. So because sickle cells cannot stack like a rouleau. So without rouleau formation, ESR cannot be fast, right? So the ESR is going to be diminished in sickle cell anemia. Then in peripheral smear, if you see, there is going to be presence of sickle cells. So there is going to be presence of sickle cells. And then the reticulocyte count, any hemolytic anemia, the body will try to increase the production. So reticulocyte count is going to be elevated. And bone marrow is going to be hypercellular, obviously. Hypercellular erythropoietic precursors. Hypercellular erythropoiesis is going to happen. So there is another screening test for sickle cell anemia, and that is called as a sickling test. So you can use 2% sodium metabisulfate or sodium dithionate. So this is actually a sickling inducing agent. This is basically this is going to cause hypoxia. These substances are going to induce hypoxia, and even so, suppose there is a sickle cell trait and it is not manifesting, or if the sickle cell anemia patients, they are not having any they are not having any crisis now. So in that case, they may not show sickle cells in the peripheral smear examination. So if you still have a suspicion of sickle cell anemia, what you do is you take the blood sample of the patient, you drop it on a glass slide, and then you add this sodium metabisulfate or sodium dithionate, and then you put a glass cover slip over it, and you put Vaseline jelly around it to prevent entry of air into it. So what happens? This sodium metabisulfate is going to create an environment of hypoxia in that, and whatever blood cells were present in that, the RBCs are going to undergo this hypoxia and they will become sickle. So if you visualize it under the microscope now, they are going to show sickles. Okay. So sickling test is a screening test which we use for sickle cell anemia. So apart from that, you can do hemoglobin electrophoresis. So for any hemoglobinopathy, you can do hemoglobin electrophoresis and HPLC. So hemoglobin electrophoresis, you can see the presence of any abnormal levels of hemoglobins, okay, but you cannot quantify the hemoglobin. But if you use a HPLC, which is the investigation of choice for any hemoglobinopathy, okay. So in HPLC, liquid chromatography technique, high pressure liquid chromatography technique, here you can actually quantify the hemoglobin, whatever abnormal hemoglobin, okay. So HP electrophoresis is based on the movement of the hemoglobin in the electrophoretic gel, okay. So HBS is going to be much more slower than HBA. So S for S, so HBS is going to be slow than HBA. So let us see. So this is the image-based questions related to sickle cell anemia. So in this image of peripheral smear, if you see, lots and lots of this sickle cells are there. So sickle cells, characteristically, you can see these many. Okay. So sickle cells are there in peripheral smear. This is the normal electrophoretic pattern here. So if you are keeping the blood sample over here, it is going to move. So based on the charge of the hemoglobins will start moving in the gel. So the HbA will be the hemoglobin which is moved the farthest. Okay, the farthest here will be the HbA. Then comes HbF, then comes HbA2. But if you see HbS, it is here in between HbA2 here and then HbF here. So it is between HbF and HbA2. So it is much more slower than the HbA here. Okay. So if you see in sickle cell trait, if you see a sickle cell trait means it is going to have HbA and S. right? So if you see in the electrophoretic band, there is both HbA band and the HbS band here. While if it is a sickle cell anemia, it is a HbSS trait. So in HbSS trait, it is more than 60% of the hemoglobin is going to be sickle HbS only, and remaining part of it is completed by the HbF. So you are going to have both HbS and HbF here. Okay, so this is HbF and this is HbS. There is no HbA. So this is the electrophoretic picture. And next we'll see the HPLC picture. So in HPLC picture, if you see, they had labeled it also. So this is the A2, HbA2, this is the HbA, and here will be the HbF. So this is the normal location. So starting from F, then A, then A2, then finally we have the HbS. So this HbS, normally there should not be any HbS, right? So the normal one should be like this, a flat curve like this. But here, if you see, both the HbA is also gone up, and then the HbS is also gone up. So what will be the actual thing here? So it is HbAS. So this is a sickle cell trait. While in the second image, if you see, there is elevation of the HbF here. So in this picture, the HbF was here only. So HbF is elevated, while HbA, this was A, right? So A is quite diminished, which is the major hemoglobin in adult. It is quite diminished here, and the HbS is again elevated. So both HbS and HbF is elevated, meaning there is going to be HbSS thing. Okay, so it is sickle cell anemia. So don't confuse between trait and anemia. So look at the question carefully. If it is A and S elevated, it's going to be sickle cell trait, while if it is F and S which is elevated, it is going to be sickle cell anemia. There is something called as HbSC disease. So as the name suggests, it is a combination of both HbS and HbC. So HbS, we know it is change of the residue of glutamate to valine at the 6th position of the beta chain of hemoglobin. So at the same 6th position of the beta chain of hemoglobin, there is going to be glutamate which is going to change into lysine here. So if valine is replacing, it becomes HbS, while if lysine is replacing, it becomes HbC. Okay.